I am a reporter with the Health and Science Desk of the New York Times, and over the past year, we've been working on a series about antimicrobial resistance. We're sort of halfway through. We've got a bunch more stories coming. But one of our primary focuses has been Candida auris, which is a fungal infection that I assume most people here have heard of. But I'm going to just assume that folks know nothing about it, and I'm going to just sort of talk about it in a very elemental way, and then happy to take questions if anyone wants to drill down. So basically, Candida auris is a very sort of challenging fungal infection that is multi-drug resistant. It's 90% of infections are resistant to at least one antifungal medication and 30% to two. And there have been about 600 cases so far in the U.S., presumably came here around 2013, and about half those affected die. So it's a pretty nasty infection, and it's mostly spreading in institutional settings, hospitals, and especially nursing homes. And the real challenge with Candida auris, not only that it's multi-drug resistant, but that it's really tough to get rid of. So basically, in our reporting, we've done a few stories on it, but we reported from a hospital here in New York, in Brooklyn, Mount Sinai, and then also a hospital in London, where folks at those hospitals had a really tough time getting rid of it. Once a patient comes in infected and goes into a room, it seems the spores spread all over the room, and it's just really tough to eradicate. In the case of Mount Sinai, they basically had to shut down their emergency room, I should say, for a few days and tear everything out. The same with Royal Brompton Hospital in London. They had to shut down their ICU and do a really thorough cleaning. Even then, it tends to show back up again in petri dishes where they're trying to grow things. So that's really one of the hallmarks. Now, it is a very deadly fungal infection, but it mostly, those fatalities are people with weakened immune systems. Obviously, the case with a lot of these resistant bugs, it's those who die tend to be those immunocompromised. In this case, a lot of those people who are becoming infected and dying are people in nursing homes, especially people on ventilators or with other kinds of invasive equipment, IV lines, one-way transmits, trachea tubes, and all that kind of thing. So it's just very tenacious in that sense. So just sort of taking a little step back, where did Candida auris come from? That's a bit of a mystery. First of all, Candida auris is a cousin of a lot of other kind of much less virulent fungal infections. The auris part refers to ear. So it was discovered, or at least first identified, in the ear of a Japanese woman in 2009. And then soon after bred, or was identified, in India and Pakistan, then soon thereafter South Africa, and it's in the last few years it's spread really far and wide. Venezuela, Colombia, Spain, the UK, as I mentioned. And there are 4 strains of Candida auris, and the peculiar thing about this fungus is that the strains are all different, and they are thought to, scientists who've looked into it say they actually 4 distinct strains that have existed for a while and that somehow became virulent around the same time. And I'll talk a little bit more about why that might be later on, but basically these 4 strains seem to have sort of exploded into this sort of virulent phase around the same time in recent years. So basically in the last few years it's been spreading across the world, and the response has, what interests us in the New York Times about it is, obviously it's a new bug that people should be concerned about, but also what it sort of highlights and reflects about the healthcare system and the sort of secrecy around infections at hospitals and other healthcare institutions like nursing homes. And what we found is that, and this may not be news to you guys because you're all sort of interested in the topic, but the institutions are not interested in revealing that they are the host of this bug. And so we come up against a lot of secrecy. It took us many months to really get the story. A lot of doctors we talked to would not really go on the record. Even patients, their families were terrified of being identified with this bug because they just felt like it would stigmatize them. So we've really run up into a lot of difficulty in terms of reporting out the spread of Candida auris. And we did have some cooperation which allowed us to put out our first story, which was in April. Since we've had a few more stories, I'm working on some other ones with a focus on nursing homes. So just sort of going back to the U.S., so the U.S., we have some idea of how it may have come here. There was a woman from the United Arab Emirates who came to New York for treatment back in 2013. She came to New York Hospital seeking care for respiratory failure, and that seems to be the earliest known case. There's also a case of an American who went to India for medical treatment and came back with auris a year or two later, and she came back to Texas quite ill and is thought to have sort of brought that back with her. And as I mentioned earlier, there's about 600 cases reported in the U.S. so far. That number actually is probably higher by now. That figure is a few months old. And most of the cases are in New York. About half of them, or actually more than half, are in New York area, Brooklyn and Queens especially. I can talk more about that later. And then New Jersey, Connecticut, Chicago area, Florida, Texas, and there's a sort of recent made the jump to California, which we'll be writing about in the near future. So in one study we saw that 50% of the residents of some nursing homes in Chicago tested positive. So nursing homes seem to be a real grounds for spreading this, and that's because it seems patients who are sort of going back and forth to hospitals a lot, they often have a lot of sort of invasive equipment which allows Candida to sort of enter. And this seems to be kind of the source of a lot of the spread between nursing homes and hospitals. Stepping back a bit, why is this happening? And it's similar to what we're seeing with antibiotic resistance. And again, it's human intervention, and it's the overuse of antifungals. In this case, there's a lot of evidence suggesting that pesticides, azole pesticides, antifungal for crops, that's used all over the world in huge, huge numbers. And there is some evidence suggesting that these azole pesticides are responsible for the rise of very deadly aspergillus lung infections. And the researchers in Holland have done a good job at sort of connecting that. So the suspicion here is that azoles could be responsible for giving rise to this sort of deadly Candida auris, the idea being that these fungicides sort of kill off lots of sort of less virulent fungi out there in nature, on fields, in the soil. And what that does is it sort of creates space for other fungi like Candida auris, which has been around for a long time, to sort of rise up and fill that niche. That's just sort of one of the theories out there. Not proven, but there's some decent evidence. And what's being done? CDC's been scrambling to deal with this. We've been especially focused on New York State. Department of Health has been pretty cooperative, and as has the CDC. And so in New York, there's an effort now to sort of ramp up surveillance, and they're considering, state officials are considering introducing a new policy in the coming months that would screen every patient admitted to a hospital, especially from a nursing home, testing those patients to see if they test positive for auris, and if so, ensuring that they are placed in isolation. And this is becoming a real burden for hospitals and nursing homes because of the need to isolate patients. They cannot be put in the same room with someone else. So you have an issue of space. So a lot of nursing homes are finding that challenging because they usually have patients paired up. So there's a problem right now in New York of nursing homes turning away patients with auris. And we've talked to some families here who've really struggled to get a loved one into a nursing home because they have auris. So it's sort of a low boil crisis hasn't been getting a lot of attention, I would say, in the mainstream media. I think part of it is the secrecy around it and also the sort of fear and stigma of those affected. But I think in the last month or two, it has been getting more attention, and there is work being done on a quick sort of a fast diagnostic test to identify it. Right now, it can take several days to get results back from a swab and up to a week, and that's largely because there's a huge backlog. But there are plans to sort of have a much quicker test that you can get results within a day or even faster. That's sort of the story, as it were, and I'm happy to take questions from anyone.
I think one of the big issues with this fungus, is that there was a lot of reluctance to report it out for a long time. Is there still residual in that area, or is it being openly dealt with?
I think it depends on the state. I think there was reluctance in New York, and now the state health department has really come on down heavy and has really been pushing institutions to report cases. I mean, here's the thing a lot of healthcare officials will say is that releasing this information to the public will just scare people away from going to the hospital. People will not seek medical care, and the fact is that Candida auris and a lot of other resistant infections will not really hurt the majority of people in the hospital. They claim that most people don't really die of auris, and I've heard a lot of doctors say this, that they feel like they're not so sure auris is killing people, but that people tend to die with auris rather than die from auris, because they say these patients are already extremely ill, and they often have other infections and other conditions that may end up being the reason they die. And that's raises another issue, is that when people do die, Candida auris doesn't appear on their death certificate, so there's really hard to track this. Yeah.
This is Kevin. I think one of the problems I've always had with that argument is that, yes, there is a healthy segment of the population, but that population is going to age and is going to naturally become unhealthy. Exactly. So that everybody would be at risk. And what this may well do is cut back life expectancy. Yeah. Certainly if you're sick and you die of Candida auris, if you're with Candida auris, you may not have died then if you didn't have that. Exactly. Granted, if you're young and healthy, you wouldn't get it, but you're not always going to be young and healthy. If you're over the age of 65, be like myself, you're going to be at risk for getting these infections. Of course sicker people get these infections. If everybody got the infection and died, it would burn out. It wouldn't spread. The real virulent organisms establish carriers in healthy people, and then when someone becomes sick, and everybody does, you then become at risk of getting the infection and can have a terminal event.
Yeah.
There is a follow-up question, but it's not reported in death certificates then. It's just sepsis, and that's that, huh?
Exactly.
That's not very helpful. Okay. Thank you.
Yeah. I was talking to an official with the New York State Undertakers Association, and they're trying to push the state to change that, because they, for better or worse, they're concerned about auris because they want to know what they're dealing with when they're dealing with the body. So they are a little bit alarmed by that. I'm not sure whether that's warranted, but anyway, it's a sort of interesting side note on the death certificate issue.
One of the other things that really struck me was that some of the nursing homes reported they have a 50% carriage rate of this.
And then Susan asks, is there any actions being taken so we can be alerted of outbreaks in real time? The answer to that would be no. And that gets back to the secrecy issue. The CDC, and Kevin obviously knows a lot about this, does not report these things in real time, and local health departments don't report them in real time. Some might, and there's no legal obligation for them to do that. And when they are reported, they will not name a hospital or an institution. As I mentioned earlier, there's a lot of fear among hospitals and nursing homes that don't want to be associated with this. And they don't want to lose the elective surgeries and the lucrative kind of hip replacements and things that they rely on. So the reporting on this is a real problem. And then Tony writes, as long as the patient's name is kept private, it's the doctor's, hospital, public health department duty to report and educate everyone and learn from it now. So yeah, I think in New York State, and I think in many states, they do report it to the health department. They'll report the case, but again, that's kept confidential. And of course, the name is never, because of HIPAA, you'll never get a name out there. But I think the problem is that even that reporting doesn't kind of come back to an institution, so you can't really know which hospital has it and which doesn't. That puts the consumer sort of at a disadvantage. And then Jonathan asks, is it like Ebola burns itself out? I don't think so, because there are cases of people who've apparently been carriers for Candida auris, and this is something that's maybe beyond my medical knowledge. There are people who are colonized with Candida auris who have been cured or have been cleared, and I guess that's because the medication antifungals do work, because like I said earlier, even though it's resistant to most antifungals, obviously it does work for some people. I guess burning itself out, I don't think probably apply in this case. And Christian writes, antifungals are included in federal legislation to incentivize antibiotic development. Well, that's good to know. Oh, but there's very little profit to be found in them, so only small biotechs are developing them, and a lot of them are not making it to the market. Yes, the FDA and CDC do seem concerned about antimicrobial resistance, but at the same time, the government's not quite concerned enough to dampen the use of these drugs. And you guys probably know most antibiotics in this country are used in agriculture for livestock. So even though one hand of the government, CDC and the FDA, are pretty focused on better stewardship of antibiotics, the EPA and the U.S. Agriculture Department are on the other hand allowing tons and tons of these drugs to be used in livestock and lately in oranges, which has experienced a bacterial infection, and also in apples. And then these azoles, these antifungals, most antifungal medication is used for crops. So it's a little bit of an imbalance there, and I think, yeah, there may need to be more leadership in Washington on this. There seems to be a little bit of a gap there. Leadership gap, yeah.
So this is the aforementioned Christian. Our frustration is often not with the people who necessarily work at the agencies. It's that the sort of legislative and executive branches don't prioritize these things until there's a big public scandal. And then suddenly they want the CDC to fix something overnight, which has been, a 20-year problem. And another area that you might find of interest is that when we talk about the idea of having up-to-the-minute reporting or real-time reporting, the reality of it is that we have so underfunded the public health infrastructure at the state level that in a place like Florida, the way that infectious disease case reports are done is by a handwritten form that is either mailed or faxed. Then the person at the Department of Health has to go through those things, decipher the doctor's handwriting, and enter it into a spreadsheet that eventually gets sent to the CDC. The amount of money to just try to start doing this is like $1 billion over 10 years, and we're fighting very hard to get it passed. I was actually talking to one of our sponsors last week, and they do terminal disinfection. And she said that she's been hearing from reporters that none of the hospitals will talk to them anymore. They do not want to talk about whether they have infections. And I don't buy, as Kevin said, I don't buy the whole, people won't go to the hospital. I think it's just that they don't want the penalties, they don't want the public relations issue, and they really don't want anybody holding them accountable. And if you can get that done, who doesn't want a system that doesn't hold you accountable? That would work for me. I don't live in that system, but...
Yeah, and I think, Christian, that kind of builds on the changing narrative. And right now, a lot of people are hearing in the other sectors is, well, this stuff's no big deal. We don't need to worry about it. And so their emphasis on cleaning up may be mitigated. Rather than performing maximal interventions, they may be performing minimal. Some of the things that I have read and heard are fairly scary. Back in the 1980s, if you had a single case of MRSA, we used to close down hospital wards. And now what I'm hearing from a number of different areas is that, well, this is nothing to worry about. And I've talked to other advocates who have heard the same thing about Candida auris, CRE, et cetera, et cetera. Now, it may not be anything to worry about until you become older or you acquire an illness. And then at that point, you not only have to worry about it, but it may be the straw to tip you over to have a fatal outcome. So I think this is a very dangerous attitude that we're starting to see develop.